Welcome all. Today this presentation will explore our case study with Kenzie and looking at her pathophysiology, assessment results, goals, exercise prescription approaches, and some comparisons to other health conditions. Kenzie is a 10-year-old female primary school student with spastic diplegic cerebral palsy as well as a history of seizures. She reports having trouble at school as she finds it difficult to keep up with friends and needs assistance with carrying books between classes, causing her to become upset. These reported difficulties in Kenzie's ADLs, as well as motivation to become more independent, are reasons on why she is seeking clinical exercise services. Additionally, guidance on achieving her goals, such as improving her walking ability, upper body strength, and posture control, can also be addressed with an EP. Cerebral palsy is a non-progressive disturbance within anatomical structures of the brain that occurs either when an infant is developing within the womb or in the early stages after birth. In particular, spastic diplegic CP is an injury to the periventricular white matter, motor cortex, and cultural spinal tracts and affects posture and lower limb movement. Symptoms include bilateral leg spasticity in predominantly the adductors, leading to abnormal scissoring gait and knee valgus, and poor posture control such as excessive trunk flexion and kyphosis. These symptoms correlate with Kenzie's reports and results in her postural analysis. Additionally, Kenzie's history of seizures align as a comorbidity to her CP, as literature has reported CP attributes to seizures and epilepsies disorders due to an injury to white matter, underlying pathologies, and abnormalities in the brain. This ICF model presents Kenzie's current physical activity behaviors and highlights the interrelationships between pathophysiology, functional limitations, and their impacts on her participation in physical activity. Due to Kenzie's CP predominantly affecting her lower limbs, this impacts her ability in postural control, walking gait, balance, and coordination, therefore acting as a barrier for engaging in physical activity. In correlation to the gross motor function classification system, based on Kenzie's current physical presentations, such as using 2-point for walking and difficulty in ADLs, it would be hypothesized that she would be classed in the grade 3 classification. Therefore, based on her goals on wanting to transition to 1-point walking, normative data on the GMFCS grade 2 and healthy populations were included for comparison and can further aid in the formulation of specific objective short, mid, and long-term goals. Kenzie's result in the 6-minute walk, 10-meter walk, and tug test indicates how her CP impacts her walking gait, endurance, and function in ADLs. Interpretation of these results include Kenzie having common disturbances from spastic diplegic CP, which may include slower movement pattern due to hypertonia, causing knee valgus and compensation efforts to retain balance in walking gait. However, her results determine promising efforts in comparison to the GMFCS Level 2 normative data, as these suggest targets and indicators to aid Kenzie's transition to 1-point walking. Additionally, the Borenson-Sonson and pediatric Berg test identified common associated pathologies with CP, as Kenzie results indicated weakness and low endurance in her back extensor muscle groups and indications of still requiring assistance for walking. These tests inform exercise prescription as well as correlates with Kenzie's goals for becoming more independent and improving her walking abilities. In current literature, additional tests include a modified Ashworth test, which would be effective at measuring muscle tone and spasticity, as these symptoms of Kenzie's condition impact her ADLs and would guide safety consideration and prescription limitations. The gross motor function measure, which would aid in tracking motor development and appropriate timelines and targets for progressions in programs. Additionally, specific performance-based assessments, which would help in creating individualized exercise intensity for programs. Therefore, tests include the BEST for standing balance, grip strength for upper limb strength, and abilities for controlling points for walking, a 5 sit-to-stand or 10 RM leg press for lower limb strength, and a box and blocks test to measure gross motor dexterity and function when reaching and grabbing. Safe considerations for both land-based resistance training and hydrotherapy programs include absolute contraindications, such as recent or uncontrolled seizures, severe spasticity, acute illness, urinary tract infection specifically for hydro, and any onset of symptoms such as dizziness, shortness of breath. Symptoms also from her current medication can serve as a severe contraindication, as these pose higher risk for injury. Relative contraindications to the client include falls risk, controlled seizures, onset of fatigue, and mild to moderate spasticity. Appropriate monitoring of the client while completing the exercise program is important to ensure client safety and reporting any abnormal signs or symptoms. Monitoring systems include the RPE scale, pain or fatigue scale, and comments or general feedback from the client. Short, mid, and long-term goals were developed to aid exercise prescription, target client-specific needs, and the quality of her ADLs. As outlined in the referral, Kenzie's primary goals for the program was to focus on improving her walking ability, standing balance, and her posterior chain and upper limb strength. These performance goals correlate to Kenzie's current impacts to participation and long-term goals of wanting to keep up with her friends, become more independent for when she transitions to high school, and being able to walk with one point. Although Kenzie's progressions and timelines in achieving these goals may take longer and with more intensive exercise processes, research has shown that short and mid goals helps in establish achievable targets that can help identify when progression is needed, build client confidence, and provide comparisons to previous performance. A range of objective targets has been outlined in each phase and is based off Kenzie's performance in her initial assessments in comparison to results from the GMFSC Grade 2 CP kids and healthy populations to guide relative measures. Additionally, based on current literature, goals in establishing modifiable walking and exercise technique through verbal and manual cues, providing education to the client and family, and the slow incorporation of exercise progressions to induce physiological adaptations has been shown to be beneficial when included in goal setting. Following the client and clinic goals and indications from the literature, the exercise prescription approach considered interventions that were client-centered, provides a detailed adaptations, progressions over time, and clear safety considerations. Within the warm-up and cool-down phases, passive stretching was included primarily in the lower limb, as research has indicated an acute increase in joint range of motion and slight reduction of muscle tension and spasticity before and after commencing exercise. Additionally, the client-centered engagement, enjoyment, and goals were also adhered through treadmill walking and Wii games, which literature has shown to improve participation in activity and confidence. Resistance training for children with CP has been shown to be beneficial in improving energy expenditure during walking, joint range of motion, balance, lower limb muscle performance, maintaining bone density, posture control, and GMFM scores. The program was broken up to target Kenzie's primary goals, with some interlinking and including additional skills development and fun and engaging aspects. Walking practice with variations, spotting, and supervision correlates with Kenzie's goal of wanting to transition to one-point walking and improving walking speed and endurance. It is further supported by literature as an effective method for modifying walking gait technique, lower limb strength, and improving confidence for participation. Progressions for these exercises include modifying the amount of assistance by transition to one-point walking practice and progressing distance or time achieved. It is important in retaining the safety of the client through spotting, positioning the client close to the wall, and supervision. Following literature, strength-based exercises for children with CP should facilitate functional performance, challenge control and strengthen posture, upper and lower limb, and correlate with client interest and current abilities. Kenzie's current physical presentations, assessment results, and goals influence the exercise selections to focus on improving strength in both her upper and lower limb, standing balance, and posterior chain through functional and engaging exercises. Each exercise incorporates safety considerations such as the setups like TRX, tricep bar for stable support, and technique adjustments to limit compromises on technique, compensation efforts, and reduce falls risk. Each exercise also incorporated an element of fun while also correlating to Kenzie's ADLs. These include facilitating upper limb reaching, grasping, and releasing while in various positions and tasks. Further progressions for these exercises promote removing supporting setups to challenge standing balance and abilities while under supervision and spotting, and slightly increases the intensity. Lastly, trunk stability and upper limb and posterior chain strengths relates to the client's specific goals and improvements in ADLs, such as walking with her books or carrying a glass of water. Research indicates the benefits of training trunk stabilization on uneven surfaces or during movement, and trunk activation extension helps to improve postural control and balance. Additionally, these exercise selections aims to improve Kenzie's presentations of excessive trunk flexion, kyphosis, and weakness in trunk extensors. Current literature for children with CP has indicated benefits in aquatic-based exercises due to utilizing water buoyancy that helps facilitate gross motor movements, weight support, dynamic balance, and improving client confidence while reducing the risk of falling. Additionally, Kenzie's interest in participating in this type of training adheres to client-specific goals and engagement. Kenzie's Hydro program incorporates similar principles as seen in her resistance program, with exercises specifically targeting walking ability, upper and lower limb strength, and coordination and balance specific. Client safety while in the pool also is considered as setups including utilizing supervision, spotting, and assisting tools such as pool noodles or ledges to ensure the client is safe but is challenged simultaneously. In relation to exercise prescription for spinal cord injuries, safety considerations in correlation to Tony's pathophysiology include automatic dysreflexia, motor restriction and lower limb abilities, bone fracture risk, accessibility for wheelchair use, and muscle imbalances and spasticity. Due to limited lower limb motor ability in comparison to a sit-to-stand exercise modifications include utilizing technology such as functional electrical stimulation to assist in maintaining lower limb muscle mass and support for performing exercise such as cycling on a recumbent bike. Research has indicated muscle cross-sectional area on average to increase by 26% and targets primary muscle groups. Client interest in the use of technology for lower limb muscle mass is also adhere, as this is a comfortable method of training. In relation to exercise prescription for stroke clients, research indicates task-oriented approaches to be effective at promoting participation, improvement in function and movement of the affected side, and correlates to client ADLs. Specifically, following the case study, due to Geoffrey's ischemic stroke occurring on the right side, he presents symptoms of dysfunction on his left side of his body, weakness in arms, difficulty in fine motor skills, and abnormal gait, which attribute to key safety considerations when performing exercise tasks. Additional safety measures can include higher fall risk, communication delay, greater fatigue, and psychological impacts. Modifications to the exercise include adjusting standing position to a B stance to reduce compensation efforts and build strength in single leg with assisting measures. The ball shooting aspect can be maintained due to clients' goals of wanting to participate with grandkids activities, but also improves upper limb gross motor dexterity, coordination, standing balance, and perception. Exercise and safety considerations for multiple sclerosis pathology correlates with monitoring episodes of relapse and heightened symptoms. Specific to Sarah's symptoms, these include greater levels of fatigue and right-sided numbness and weakness, which greatly impact ADLs such as stair climbing, muscle strength, and sensory input. Additional considerations include temperature regulation, delayed cognitive response or sensory feedback, medication side effects, and mood changes. Exercise modifications to the sit-to-stand include modifying to a step-up type exercise to promote closer asymmetry in strength and balance, lower compensation efforts, and correlates to client-specific ADLs and goals. Research also indicates imbalances of 20 to 30% in muscle weakness between the affected and non-affected side of the body. Therefore, single limb-based exercises are effective at targeting improvements in performance. The ball shooting aspect promotes similar outcomes to the stroke patient, but can also be modified to a netball-based setup, as the client expressed previous experience with the sport. For the second exercise modification to the seated yoga ball balance with upward reaching, for Tony, our spinal cord injury client, due to safety considerations, the setup of the exercise would be in a stable chair for seated balance. While retaining balance, the reaching aspect can be modified to include reaching in multi-directions, grabbing various object sizes and shapes, or introducing AFL passing and catching drills. Research further supports this method of training as it indicates improvements in dynamic seated balance efforts while also enhancing sensory input simultaneously. After his stroke, Geoffrey's left side is primarily affected with weakness and minimal use. In correlation to clients' limitation, clinical presentations, and goals, literature around exercise approaches incorporates cognitive dual tasking exercise, which helps improve cognitive function, coordination, and greater ability in performing and completing tasks. For the seated balance and reaching exercise, following similar safety consideration, modification exercises utilize Bozo ball instead of the yoga ball to incorporate improving seated balance, limit falls risk, and work on compensation efforts between the non-affected and the affected side. The reaching aspect can be modified to a fine motor task such as a pinboard, drawing, or writing, as this greater relates to the client's dysfunction and ADLs and goals. Following current literature, dual tasking for clients with MS has been shown as a beneficial aspect of exercise, as it helps improve dynamic balance and functional mobility. The second exercise modification includes transitioning to standing balance on a firm surface or foam mat, as this correlates greater to client goals and condition. In addition, while balancing, the client will perform dual tasking by reaching and grasping objects in multi-directions. Safety considerations include, during flare-ups or relapses, additional assessing tools to retain balance, or regressing exercise may need to be considered depending on client symptoms.